Hello, good evening, everyone. I am Dr. Vaishnavi from the team of Voice of Healthcare. A very warm welcome to today's live session on the evolving role of diagnostic testing in lung cancer. This session is supported by Roche in public interest. Lung cancer continues to be one of the most challenging cancers in India, mainly because a majority of patients are diagnosed only when the disease has progressed to an advanced stage. Over the past decade, however, we have seen remarkable advancement in the diagnostic science. Technology that were once confined to specialized center are now becoming more widespread, improving the pathway for suspicion of disease to diagnosis and eventually to personalized therapy. Today's conversation is focused on understanding how modern diagnostics, particularly low dose CT screening, reflex molecular testing, and early biomarker identification, are reshaping the landscape of lung cancer care. Low dose CT has emerged as a highly effective screening tool capable of identifying lung abnormalities long before symptoms appear. We will also be discussing the significance of reflex testing, a process that automatically initiates essential molecular tests as soon as a tissue sample is collected. Another major component of today's discussion is the early identification of biomarkers such as EGFR, ALK, ROS1, and PDL1. Before we move into the discussion, I'm delighted to introduce the esteemed panel joining us today, leaders in pathology and onco-diagnostic who bring a wealth of expertise and insight. Dr. Shantveer G. Uppin, Professor, Department of Pathology, Nizam Institute of Medical Sciences, Hyderabad. Welcome to the session, sir.
Thank you.
Dr. Kunal Sharma, Vice President and Head, Integrated Onco-Pathology, Agilus Diagnostics. Welcome to the session, sir.
Thank you, Dr. Vaishnavi.
Dr. Amanjit Bal, Assistant Professor, Department of Histopathology, Postgraduate Institute of Medical Education and Research, Chandigarh. Welcome to the session, ma'am.
Thank you. Thank you.
So we are truly honored to have such distinguished panel with us to explore the scientific, operational, and system level elements that define early lung cancer diagnostics in India. So to begin with, my first question is to you, Dr. Shantveer, that many high risk individuals still do not undergo CT screening until symptoms appear. So, from your clinical experience, what are the real world barriers, fear, cost awareness, and access that keep patient away, and how can hospital help them overcome these?
I feel the main thing this is the question which requires answer from a clinician, but as far as a pathologist, what I come to know about it is patients are afraid of getting CTs because of the high dose of radiation exposure. That's what is I think the most of the patients are worried about because of the later effects of radiation on a patient. So usually they would not most of the times chest x-rays they are ready to get it done, but CT as the thinking among the public as well as in some of the non-expert doctors is also that it has a low exposure to a lot of radiation instead of a routine CT which has more exposure. They don't understand that the low dose CT the exposure is not much and especially needs to be done in patients who are at high risk, like certain after certain age group and smokers, and that this is the best modality for early detection of cancers, which can be treated surgically. Otherwise, most of our patients present with advanced cancer at presentation.
Okay, so thank you for bringing it across to us and explaining it. My next question is to you, Dr. Kunal, that for a typical patient walking in for lung screening, what would be an ideal patient-friendly pathway look like from the first scan to getting the clarity on what the finding actually means? So, what is your view on that?
So I think this can be divided into a pre-scan treatment, the scanning procedure, and a post-scan treatment of the patient. I think one of the most important things is to have a dedicated patient coordinator, or a SPOC who can explain everything in detail and comprehensively to the patient in a non-medical jargon. uh, then it's important to understand what is the patient expectations, to brief them about the procedure during the procedure, to also take care of them if they're feeling, let's say if they're feeling cold, to provide them with a blanket, or if there is a good ambient music, the environment in which they are in. And once the test scans are done, then it is important that those test scans are made available promptly. Turnaround times are extremely important because that is the area, that is the time period during which patient anxieties are at the maximum. So it's important to have a good radiologist assess that scan and to give the result promptly. That result should be accessible to the patient. There should be probably a patient interaction module in which the patients can access their reports early. And also, once the reports are available, whether then we can either have a negative result and or we can have a positive result. So if the patient has a negative result, it's again, you treat them in a way that you tell them that it's a good news that they don't have any significant pathology, but they must always do regular follow-ups as is clinically advisable, in case of, depending upon the clinical features and what you're suspecting. But in case the result is positive and we are talking about a more sinister pathology like cancer, it is then important to clearly communicate to the patient, to address that result with proper experts, including a multidisciplinary team, and to then tell the patient very clearly about the fact that they should not worry unnecessarily. There is treatment available, and that they have to go step by step and to help them throughout that process. So I think this forms a very succinct and a very clear workflow in cases of when a patient visits for his first scan, his or her first scan.
Okay, so speaking about the low dose CT screening, so when a low dose CT scan picks up early abnormalities, so what are the key clinical clues or subtle findings that you believe should be given prompt and immediate attention?
So I think some of the things that one can pick up in a low dose CT is, of course, the size of the lesion. When a patient first presents with a lesion, let's say if it is about 8 or more in size, or if it is, if it's a previous lesion and it has gone for about 4 or more in size. The other thing that somebody can that gives you a clue is the growth rate of the lesion. So what they define it as a volume doubling time of less than 400 days. So that is a very strong predictor of something that you should be careful about. Then there are other findings like mediastinal lymphadenopathy, if it is there. Also that you can have vascular changes which are very whenever there is cancer or a significant pathology, there is neovascularization that takes place. So that can be seen in the scans. From a clinical symptomatic perspective, I think if you have non-resolving respiratory symptoms, some, if you have cough, if you have hemoptysis, that is blood in your sputum, if you have those kind of symptoms which are not resolving, then you need to be careful. Also, if you have unexplained systemic symptoms like unexplained weight loss, night sweats, so or if you suspect an infection in a patient, for example, and the clinician gives antibiotics, but the symptoms don't resolve. So again, these are all clinical cues that can would probably imply that you need to go ahead with further testing.
Okay. Yes. So my next question is to you, Dr. Amanjit, that when the CT scan detects small nodules or intermediate lesions, so what are the key steps that should be ensured in order to ensure that the case is not lost to follow up and that patient receive timely, appropriate diagnostic confirmations?
Okay, so the first step is when radiologist has diagnosed the nodules. So there are clear-cut guidelines. So they have to classify those nodules whether they are infection related, they are benign, or they are probably benign, or they are suspicious. So that should be accurately documented on the patient form. And if it is benign, then they ask the patient to get a repeat scan done at an interval of 1 year. And if it is probably benign, or like the radiologist is not sure what they are dealing with, then they tell them to come back for repeat scans at 3 monthly intervals or maybe 6 monthly interval. Like they assess the malignancy risk from those radiology images, and if they find it very suspicious or they think it is going to be probable malignant, then they guide the patient to get a PET evaluation done and get a biopsy done to get a tissue diagnosis. So that is based upon their radiology opinion, what they are thinking of. So once they have guided the patient, if they have to tell the patient to come for a repeat scan, I think it's better they write a date that on that particular date the patient should come back, because if they say come back after 1 year, so some patients might not come back, right? And after this, there should be a correlation or MDD between clinician, the radiologist, and the oncologist. So because they will take a decision how to go about it. And very important is there should be a lung cancer screening registries should be there, where there should be a coordinator which should call the patient. Like if they have called that particular patient for after 1 year for a repeat scan, then they should call him, make a phone call and tell him to come back for a repeat scan. And if it is highly suspicious lesion, then they should guide that patient where to go for PET imaging, how to get the biopsy done. And after biopsy comes positive, then it becomes more important that MDD should be held, how to go about the molecular testing, and treatment plan should be charted out for that patient.
Correct. So I think we'll be having these follow-up questions also in depth in the session going forward. So my next question is to you, Dr. Shantveer, that many patients face delay because reflex testing is not initiated automatically after the first biopsy. So in your view, the what key process or gaps are there in terms of communication, awareness, or logistics, which needs to be fixed so that patient do not lose these critical weeks?
Uh, and this often happens if all the facilities for next level testing is not available in house in that hospital, or if it is being referred from a hospital which doesn't have reflex testing for biomarkers in their setup, then the patient will be asked to go to other centers, and the patient may himself delay, or sometimes it may be delay from the communicating pathologist also, that how important it's to do a reflex testing. But ideally, if it is in a center where these lung cancers are managed regularly, then there is a system in place where these tests usually at the lab level, like if you say example, in our setup, we since we do a lot of lung cancer patients, once the biopsy comes, we find that it is definitely a malignancy, then we definitely go reflex testing for these biomarkers. So that is done at lab level only. Decision is taken before we receive the. We can give a preliminary report saying that it's malignancy, and we say that the following ancillary tests are being done, and it will be following this result. So that should be the methodology that should be done. The problem happens when the testing is not available in house, and the patient needs to be referred to another hospital or a center, or it is being outsourced. There are the things. And also sometimes if it also depends upon the financial, if the patient has to pay for himself, sometimes depending upon, especially if your patient is poor and all, they are not cannot afford these tests, and they may delay themselves for getting these tests. But if it is included in the same hospital, everything is done as a package. Once the sample comes, if it is reflectively tested, then it becomes easier for the patient. Otherwise, there are several things that can influence testing time, especially the decision to decision of the if the patient has to take a decision whether he needs to get tested or go for additional test, or that usually delays the process. If it is done at the level of the labs, if they are allowed to do the test reflexly depending upon their diagnosis, that is the best methodology I feel, and which we follow in our setup, where we reflexly test once we have a diagnosis of, say, non-small cell lung carcinoma or morphology.
So I was going to ask the same question, that what are the most common reasons that clinicians or labs miss out on essential molecular tests? But I would like to understand from your point of view that what practical or low effort changes could ensure that every eligible lung cancer patient receives a complete and timely workup.
I think, especially since I come from a government setup where The patient, most of the patients we see are poor patients and maybe lower middle class patients. And as these testing, depending upon the platform you use, requires a lot of money. If this is supported, if the testing for a cancer is supported by some government like insurance program, or it is part of a, because we in our setup it is like, if it is, we do as a part of a project, diamonds project, which we are doing. So where every patient gets all the test biomarkers, including the IHCs and molecular testing, free of cost. So then it is at upfront when the biopsy comes with a suspicion of a lung cancer, we take the consent for doing an additional molecular test if required from the patient at the time of receipt of the sample. So if that happens, then the patient will get the complete report without having to wait for the payment, wait for the decision of the clinician and all those things, because this is already in the system and the clinician knows that they will go for reflex testing if it is a suspicion of malignancy or a proven malignancy on routine HID. Most of the time, the delay happens if it has to be done in a non-reflex way. If there is somebody who has to take a decision, either because of financial reasons or any logistic reasons, if there is a decision needs to be taken in multiple steps, this often results in delay. If everything is together as a package, either, and if it is a, especially for poor patient, if it is financially supported, then it's not a problem. It usually happens that it is done together, and the best of the testing time can be saved by doing this testing by reflex method.
Correct. So yes, I believe that challenge someday gets filled and that gap is addressed. So my next question is to you, Dr. Kunal, that reflex testing often requires coordination between the treating clinician, imaging, and the laboratory team. So based on your experience, what does a seamless workflow look like where the patient never has to return to repeated biopsies or repeated visits?
So I think one of the most important parts of this is to understand that first of all, the biopsies that are taken, they need to be taken in a guided fashion, so that you hit the lesion and you take adequate number of cores. They can, I mean, in lung cancers you can easily have up to 10 cores. And what you can also do is that mostly, many a times in lung cancer patients, what happens is that tissue is the issue. Okay, because we usually get extremely small amount of material, and we have to do histopath evaluation, we have to do IHC, we have to do molecular evaluation. So one more thing that can be done is that when you get adequate number of cores, you can divide them, you can see the tumor content in each core, and you can simultaneously proceed with your histopath IHC at one side and your molecular evaluation at the other side, so that there are no delays, there is no significant depletion of the tissue during HE and IHC, and you have enough tissue which is available even for molecular evaluation. Another thing which is important is that it's very important, like I am in a tertiary lab setup, and we get samples from across the country and even from other countries. So what's important is that the samples need to be fixed properly. Otherwise what happens is, if these are not properly fixed, if they haven't used 10% neutral buffer formalin, then in those cases you know uh, I mean, you are not able to give proper results, and patients have to undergo a repeat biopsy. uh, if in case you are biopsying metastatic sites, especially if you are biopsying something like a bone metastasis, we know that if we use a lot of decalcification, we harm the genetic material, that is the DNA and RNA. And when we subject these for molecular evaluation, we don't get proper yield and we do not get the right answers. So in you should avoid using such sites. But in case you don't have any other option, and you're using let's say you are biopsying a bone metastasis, then you make sure that you do soft tissue dissection techniques, you use EDTA based decalcification methods, in which the harm to DNA and RNA is less. So these are some of the factors which you can incorporate in your practice to ensure that in one go you get a good yield, and the patient doesn't have to be subjected to repeated evaluation. Another very important aspect in this case is the advent of liquid biopsies. Sometimes I mean, you need to have both solid tissue biopsy as well as liquid biopsy at the same time. And in case something is not detectable, let's say in a recurrent setting, Okay, recurrence metastatic setting. If something is not detectable in the solid tissue biopsy, you have the liquid biopsy, and with that you can proceed for ctDNA and target mutation testing, and you don't have to subject this patient for another CT guided biopsy. So these are just some of the steps that you can take, I believe.
So, taking this forward, my next question is to you, Dr. Amanjit, that in many cases, the tissue obtained is just enough for diagnosis, but not enough for the molecular workup, which we mentioned in the previous question as well. So, what strategies of sampling technique, communication, or protocols can help ensure that the first biopsy itself is adequate for a full diagnostic and molecular profile?
So I think it's just a repetition what Dr. Kunal just said, but I think the first level point of communication is the pulmonologist who should fill the form, requisition form, that it is a case of suspected lung carcinoma. The interventional radiologists or the PET nuclear people, they should take adequate number of biopsies. So 10 probably will be too much. I think 3 and 5, up to 3 to 5 will be enough, but it should be very clearly mentioned. So what we have seen is like CT guided biopsies versus PET guided biopsies. So PET guided biopsies have a way more yield and they hit the right viable tumor area, and the yield for both diagnosis and molecular testing is much better as compared to the CT guided biopsies. And it does two functions. So it does the staging for the patient also, and at the same time you acquire a tissue for diagnosis and molecular testing. And the same requisition form which goes to the radiologist comes to the pathologist also. So pathologists also know that it is a case of suspected lung carcinoma. So either the radiologist who is taking biopsies, they should like put these cores, if they have taken 5 cores, they can put it into 3 separate vials, because otherwise it can be done at a pathology lab also. But if it is sent in a separate vials, then the pathologist will tend to form 3 separate blocks, sometimes if they send it in one vial, the pathologist, while the grossing person who is the junior most person tends to put it all the cores in one block, so that creates problem at a later stage. So 2 block strategy or 3 block strategy is way better than a single block strategy. And secondly, if they are doing FNAs, sometimes they are not doing core biopsies, but we prefer core biopsies better than FNA. But sometimes the lesion is not accessible for biopsy, or they have to do endobronchial biopsy, or they do EBUS TBNA from the lymph node sampling. Then it's better to do rapid on-site evaluation whether the tissue or the tumor cells are adequate for diagnosis and molecular testing. So that we are using in PGI. So either now the pulmonologists are trained to evaluate the tumor content, and previously they were sending us the images to see if this slide has adequate tumor tissue or not. So that will prevent the repeat FNAs from the mediastinal lymph nodes. So that is other. And third is like it should reporting should be done by a specialist pathologist who is dealing with lung cancer, because I have seen that non-specialist people, they keep on doing numerous IHCs which are not required. If there is a doubt, I think it should be limited to only 2 IHCs, that is TTF1 and P40, to differentiate whether it is adeno or squamous. So that will preserve a lot of tissue for molecular testing also. So these are the few points which we keep in mind to preserve tissue.
Correct. So, my next question is to you, Dr. Shantveer, that for patients who cannot undergo invasive biopsies due to age, comorbidity, or cancer location, how do tools like liquid biopsy reshape clinical decision making and provide an alternative route to timely diagnosis?
Definitely, liquid biopsy now is an established thing in, especially not only for patients who cannot, because of comorbidities and all, if the biopsy is difficult, but in certain situations like where, see, liquid biopsy has an advantage of that you can do a serial testing instead, like you can't go on, especially if the patient you want to monitor the response or a resistance, if a patient on treatment develops resistance, or if there is a recurrent tumor, you can't go on repeating the biopsy. But liquid biopsy has an advantage. It's a non-invasive procedure, and once you establish a primary diagnosis, uh, liquid biopsy is helpful in monitoring the response to therapy, as well as any possible chances of recurrence, or if they are already on a TKIs, there is a resistance developing later or progressing on TKIs. Therefore, you want to any resistance mutation has developed, instead of doing a repeated biopsy, just because lung is a site where is even the biopsy is associated with a lot of complications which can arise, and you cannot go on, and patient's compliance also will not be good for having a repeated true cut biopsies. But and liquid biopsy is very helpful. Not only that, studies have shown that because tumors have a lot of heterogeneity, and when you do a biopsy, true cut biopsy, it is form particular portion of the tumor. But when you have a liquid biopsy, it addresses most of this heterogeneity as well as, and it has an advantage that it can be done serially multiple times without having a problems for the patients. So I think liquid biopsy has established, and more uh, people start doing it, get an expert, because it requires expertise and proper equipment, infrastructure available, and also so all that if it develops, then that is the best way of managing patients, especially who are on treatment, and following up, monitoring the response to therapy. This is the best.
Okay. So my
And
next
also, as
question.
Kunal, I just wanted to add, Dr. Kunal was telling, if you at upfront also, if you can do both together, parallel sampling of uh, a core biopsy plus liquid biopsy, studies have shown that there is an increased percentage of detecting this, because some mutations may not be detected on a tissue because of various reasons. Maybe the mutation is the tumor biopsy has been taken from a particular location which has a very low allele frequency, or it may be that tumor tissue is lot of necrosis where your tissue is not suitable for molecular testing. So several things. If you do a combined like parallel sampling, your chances of having a mutation may be high, and also possibility of detecting several tumor subclones with different mutations and all. So sometimes you can have combined at upfront mutations. We have seen where you can have an EGFR L858R plus 3079 and 90M mutations. So all these things, and liquid biopsy has an advantage. And as we go on doing more and more, we will find it more useful and more patient friendly, I must say, because of the you can take a blood sample or a body fluid samples to do the test.
Okay. So my next question is to you, Dr. Kunal. With fast-growing innovations like digital pathology, AI-assisted image interpretation, and faster NGS technologies, which advancements do you believe will make the most immediate and meaningful difference for lung cancer patients in India?
So I think all of them have their own specific part to play. We know that digital pathology and AI algorithms are bringing in phenomenal amount of objectivity into our reporting. We also have biomarker estimations like PDL1, which are based on these are quantitative estimations. So there is numerical value associated. We all know that in histopathology especially there is a lot of inter-observer variability. So digital pathology and AI algorithms play a role to mitigate that. Another thing is we know that there are newer biomarkers like TROP2, which are coming in, in lung cancer, and we already know that FDA has approved, a digital pathology AI algorithm for TROP2 estimation. So all of them definitely play a role. But if you ask me about one, I would say NGS will be the biggest game changer. It will be little more than digital pathology and AI. The reason I'm telling you this, especially in an Indian scenario, is because Asian and Indian population specifically, we see a lot of they have a higher percentage of mutations when we compare it to the Western population. So we know that lung cancer in India is heavily biomarker, mutation driven, and thereby if we have faster NGS platforms which are available, I mean this could mean faster workflows. This could mean platforms like the GenXS platform, for example, that we have, in which the assessment and bioinformatics aspects are reduced to quite a lot. Or this could also mean very specific mutation testing. You don't have to go for very comprehensive genomic profiling, but you go for the more commoner mutations, and you are able to give results in a fast turnaround time. So I think testing lung cancer patients for mutations will definitely be a game changer, and I would definitely like to include the role of liquid biopsy, as we have already discussed. Myself, Dr. Uppin, both of us have mentioned. So I think all these technologies have their own role to play, but molecular testing, genomics, and NGS, it is here to be the most or the biggest game changer, if I may say so. And important aspect is like what Dr. Amanjit highlighted. Specialists of oncopathology or of particular systemic pathology are important. I don't agree with a remark that at the max only two IHCs are needed. We've had cases where that has been extremely misleading. Like one case was of a large cell neuroendocrine carcinoma, which looked quite a lot like NSCLC adeno, and we had a lot of necrosis, and all three neuroendocrine markers came positive. And in those cases, for an adeno, we have to go for a specific molecular panel, but for a large cell neuroendocrine, all that might not be needed. But again, that stresses her point that you need specialists who deal with these cases, because we know, especially in tier 2 and tier 3 cities, this can be an issue. Patients show biopsies to anyone and everyone, and what comes out of it is, very, very detrimental.
Correct. So my next question is to you, Dr. Amanjit, that as biomarker testing evolves rapidly, which early markers or new molecular insight do you feel will significantly change how we identify lung cancer in its earliest stage over the next few years?
That's a very difficult question. Like detecting new markers, which will tell us whether this patient is having lung cancer, is probably not in practice. But like some people are doing DNA methylation testing, which can tell or predict early cancer evolution. But at least what we can do, what is already there in practice, should be done faster. But having said that, first I will come to Dr. Kunal's point. So I agree with you. If the morphology has a neuroendocrine suggestion, then we should add a third marker. So that's like important point which he highlighted. And secondly, the major in India or in the Asian countries, the major bulk of mutations are in EGFR, that is to the tune of 30 to 40%, and another 10% is ALK rearranged, and another 3% is ROS1 rearranged. So if we can do it upfront, once the patient is diagnosed as adenocarcinoma, that will take care of at least 40-50% of our lung cancer patients. And simultaneously you can send NGS, because there is importance of co-occurring molecular alterations also, like EGFR plus TP53. The patients are not going to behave similarly as they are without TP53 mutations. So I think four upfront things: EGFR, ALK, ROS1 plus PDL1 if it is squamous, or if it is even adeno. And the turnaround time will be only 4 to 5 days for this if you are doing single gene testing. And simultaneously you can send NGS also. The turnaround time will be around 3 weeks. They are cutting it down or bringing it down to 2 weeks also, but at least within 1 week the patient can get treatment if he is having one of these molecular alterations. And the frequency of other mutations is, I think, extremely low. It's around 1%. But now we have a drug for KRAS G12C also, so that also needs to be tested, because that also has high frequency in Indian population.
Correct. So, for our viewers who are watching this session live, I will ask some basic questions, as in, what is one misconception that patients commonly have about lung cancer tests that affect the early diagnosis? So, Dr. Satwir, maybe you can go first on this one.
The thing is, many of what I see in practice is many of the, especially if it in periphery, most of these lung malignancies on a chest radiograph, initial chest radiographs, are suspected to be TBs, and they are treated empirically even without doing a biopsy. That is many of the things, many of the times the patient, because our patients, the incidence of tuberculosis is quite high. Many of the lung lesions at initial stages are, even without biopsy, managed empirically as tuberculosis. That becomes a lot of problem, and by the time the patient doesn't start responding to TB, then they start thinking of malignancy, and then they start doing biopsy. The patient has advanced malignancy. So high index of suspicion, especially in vulnerable population like age group and smoking history, there should be a high index of suspicion of malignancy, and the biopsy should be done immediately. When it is the best treatment is surgical if it is caught very early. But most of our patients, if you see it across India, the patients come at an advanced stage where it becomes difficult. So the thing is to have a high index of suspicion of a case being a malignancy, especially in vulnerable individuals. And do a prompt biopsy to establish a diagnosis. That is very important. And many of the patients will get treatment for other things before they get biopsy done. That is what I feel leads to a lot of delay in diagnosis in our setup.
Correct.
Vaishnavi, I would also like to add, I think if this is about patients and their misconceptions, I think a very common misconception that a lot of patients has is that lung cancer only affects those who smoke. So it's also important to understand that lung cancer is very much prevalent in non-smokers, and a non-smoker who has symptoms which could be symptoms of lung cancer, uh, or if it's a high risk individual who has smoked in the past or is an elderly individual, then these individuals also need to be followed up, or they need to, if at all we are talking about screening programs, then these also are individuals who need appropriate screening and follow-ups.
Yeah.
Correct.
So I would also like to add here, because some people say we don't have any symptoms, so why should we go for screening? So that's also not true, because our screening aim is to catch lung cancer at this stage so that they can be surgically resectable. But
Very
unfortunately,
right.
here more than 70% are already metastasized. So that is the aim of screening, to catch it early. So, reformed smokers are also not risk free, and even in females, the incidence is rising. Around 20% lung adenos are in females now.
Correct. And
Correct.
I
And we
think, Dr.
forget the
Amanjit, you will agree
biomass
with me.
fuel also,
Yeah.
yes.
That these are usually the people who show a lot of mutations also, like the non-smokers, early age, and females. So it's important, as she rightly said.
Correct. Also, ma'am, if you can highlight that now we have so many hospitals across the industry. So, what steps can be taken at hospital level to ensure that these tests happen early without delays, so that clinician can confidently choose the right treatment pathway? So, what steps can be taken at a hospital level?
So, in India, I think the tertiary care hospitals or the referral hospitals are already equipped, at least for limited gene panels. But the periphery hospitals, it is a difficult scene because they do not have infrastructure, or they are like, once the patient is diagnosed with carcinoma lung, either they should be referred to a tertiary hospital, or like, I think Shantveer will be able to tell better, because they have that diamond project which can do these molecular alterations early and free for patients who cannot afford costly NGS. So I think these type of government schemes should be there, and which should guide the patient, and at least limited panel should be done for all these lung cancer patients.
Correct.
Amanjit, if I can come in here, as Amanjit rightly said, many of the patients working in a government setup. Earlier, I am telling the scenario before I established this as a part of Diamond Project before, and what we used to practice. We used to diagnose lung cancer, and we used to tell them that this requires molecular testing because we didn't have an in-house facility, and we because the patients were not ready to, means they don't, many of the times patients can't afford this testing, and many of our patients who come don't have insurance and all, because our patients are all from poor and lower middle class patients who didn't have any insurance and all those things. So it always used to get delayed depending upon when they go and get it done from a outside center or a laboratory or a hospital. But we once we established this as a part of the help of DHR and ICMR, our center was selected as a diamond center for establishing advanced molecular oncology. In this, as a part of this, we do free testing for lung cancer and breast cancer. So now the thing is, a patient with lung cancer comes, we do the initial HND. At the time of HND only, we get the additional sections for ALK IHC, PDL1 IHC, and ROS1 IHC. We are doing it irrespective of whether it is going to be, though we know it is less percentage and all, because we know that the tissue next needs to go for PCR testing where the sections will be exhausted, tumor is exhausted. So it is look, so we don't have that restriction of pricing or money and all for the patient. So we are able to test it, and that test immediately goes for EGFR testing. So because of this, the patient doesn't have to do anything. We are giving them a final report. And not only that, this facility we are extending to the other hospitals in the periphery, because this entails that we should do it in 120-kilometer radius of our center. All these centers we have already written that these tests are done free of cost for lung cancer. So whenever they diagnose in the periphery where they don't have facility for this molecular, they are referring the samples. We are doing them free testing and sending the reports online to them. So this has made a lot of difference. Actually, if you see the number of patients we have tested in the last 1.5 years, is more than 600 cases we have tested for all the biomarkers. And majority, as Dr. Amanjit rightly said, the most important ones are EGFR, we found majority, followed by ALK around 10%, then comes ROS. And we started doing KRAS in those which are T negative, like these ALK ROS, and we found these are because earlier there was no specific treatment for this KRAS positive tumors. We were not doing. Now, since our clinicians are insisting on getting that, so we have started doing that also, and we have found a good percentage of cases where this KRAS is coming positive. So it depends upon it. If you are doing it as a reflex without any additional cost to the patient, that is the best strategy for covering large number of patients. And also, these tests cannot be established in every place at the periphery because this is not cost effective. So it has to be a centralized referral methodology, and you should have experts in pulmonary pathology or oncopathology who can interpret this so that they don't waste the tissue for diagnosis itself. They should make a prompt diagnosis with the minimal of IHC and go for reflex molecular testing without wasting the tissue. That is the way to go forward, I believe.
Correct. I would like to ask Dr. Kunal that what small improvements in biopsy technique or communication can dramatically reduce inadequate samples?
So I think we have discussed some of these already. Some of the important things that people need to take into mind are the fact that these should be guided biopsies, because then these should be live guided biopsies. Usually these are CT guided biopsies, and where where is the lesion and you can hit the right lesion. Uh, you can clearly make out, it should not be a necrotic area, and otherwise you will be missing out on representative tumor tissue. You should use the right set of needles. Then you should make sure that these samples are fixed appropriately. As far as communications go, again, from a laboratory perspective, we send out communication handouts to our clients on how to handle these biopsies. You should make sure that you don't mishandle them too much, because otherwise those crushing artifacts will come while you're evaluating them. So I've already told you about metastatic sites and how to handle, let's say, if you get a bone metastatic biopsy. So I think these are some of the things that you can do to make sure that you get a good yield, good biopsy in the first go itself.
Correct. So as we are heading towards wrapping up the session, my next summing up question is to you, Dr. Amanjit, that how can screening awareness be strengthened for smokers and other high risk groups so that we get some outcome and we try and do our best for this condition?
Yeah, the best way is, educating people. So there should be like patients, the smokers come to hospitals. The first step is the pulmonologist should guide them, and they should tell it's by word of mouth. Then there should be seminars, there should be camps. But having said that, I think in India the screening programs are not taking up like they are in the West. And if you see, even the breast screening program is not very good in Indian scenario. So I think education is the most important step. Like we have to educate people in a English, in a easy language, so that they understand that screening will help them only to detect if they are getting malignancy at an early stage, which will have a way better prognosis as compared to when we diagnose them at later stages.
Correct. So, thank you so much. I mean, we have covered most of the points which were related to this topic. Thank you for making out time and joining us live today. I hope it was a good discussion with all of you, and thank you so much for joining us today.
Thank you.
Pleasure.
So,
Thank you.
Thank you.